Just before we really get started with the presentation today, because we're talking about the upstate New York CBO Technical Assistance Grant, and kind of want to give you a little bit overview of that as well as answer your questions. But how many of you were at the March 8th kickoff for that CBO project here in the Capital District? Good. Well, you're going to hear some of the things repeated today, but you're also going to get to hear about the experience down in the Long Island area. Emily Rogan will talk about what they've done, because we're really in the formative stages. They're farther along, and I think we should be able to offer some good perspectives about what's in it for CBOs, why you can get involved, and why it's important. How many folks are here from CBOs? Most everybody here. How about the PPSs themselves? Yes. And providers, MCOs, any? Good, good. Well, appreciate you coming to this session today. It was a great introduction. I'll have to talk to our office, but they did a good job writing up the bio. It's good to be here today, and well, really, I guess I have the clicker so I can move this thing ahead a little bit. We'll see if it works. No. There we go. You've heard about our presenters, and talk a little bit about the goals of the session. Really, a few years ago, probably most of us that are from community-based organizations really wouldn't be in a meeting like this. And I think it's significant that we're here today, and I really want to thank the Department of Health and for a lot of the PPSs and the policymakers who have invited us to participate in this aspect of healthcare transformation to come and talk. And there's a lot of reasons why we wouldn't have been here, because most of the time, healthcare reform was a top-down type of thing, medically driven, often following changes in payment structure and so forth. So first of all, we wouldn't have been invited. We definitely wouldn't be provided with a technical assistance grant. That's really a wonderful thing. Again, in the 44 years I've been working on this issue, that's a real first. And we absolutely would not have been paid to participate in some of these things. And so there's now some financial incentives there for us as well. And I think those are very significant things. It's really kind of a confluence of a lot of different factors. Those of you who were listening to some of the other workshops or maybe came to some of the value-based purchasing are really steeped in this now, and you're pretty far along in your journey. But for the rest of us that are kind of at the beginning, it's a recognition that at the federal level, healthcare reform has really made some changes that are significant in terms of focusing on the needs of the population and really trying to reduce readmissions to hospitals. And here in New York State, we have this DSRIP initiative, but a big part of that, thanks to a lot of advocacy from different organizations, is really to bring community-based organizations and human services agencies to the table, and that's significant. But also the financial incentives are there now. The value-based purchasing is really talking about doing things that are focused more on quality of life, and to be pretty blunt about it, used to be dismissed at meetings I'd go to as kind of superfluous, nice things to do for people, warm and fuzzy. Have you heard those things? But now the evidence is starting to catch up with the reality of those are the types of things that are really needed to keep people independent, to have them have good healthcare outcomes. You really can't focus much on, getting to your doctor's appointments when you're worried about a roof over your head, or maybe food on the table for your kids, or you don't have a car and you've got to get transportation across town for necessary therapy. So now evidence base is starting to support that. We have a long way to go, and I think that those resources that are provided on this project will help us get there, recognize the importance of some of the things that community-based organizations do. We all have the same mission. We're working to help our communities be better, healthier places. So supporting things like housing, nutrition, transportation, counseling are absolutely critical. So the PPSs have come a long way in terms of supporting the involvement of community-based organizations, and the PPSs that are at today's conference is an example of that. The three have come together and really outwardly encourage us to come. So today we're going to talk a little bit about how we can harness the collective power of the community-based organizations to have a bigger impact on systems reform. We're going to talk about the purpose behind the DSRIP CBO Consortium Planning Grant. We'll hear from Emily about the Health Equity Alliance of Long Island, their experience. we're going to learn about the newly formed Upstate CBO Consortium and how you can get involved in that. And if you haven't gotten signed up for that, we have applications to join the consortium, so you can find out how to get involved. God, I'm 2 for 2, getting it to move ahead. I'm very proud of myself. In terms of community-based organizations, really, I think you've heard a lot of great examples this morning, and I think it's significant that you have, physicians up there at the head of the table talking about how they're asking people what's important to them. And some of those things are medical in nature in terms of the responses, but a lot of them are really focused on other needs, very personal needs. And there's a recognition that community-based organizations like those here in the room today are locally rooted. They're focused on the needs of their community or their neighborhood, and they're a much better way to reflect back those needs and work with the healthcare systems. We have a long way to go towards making that happen, but certainly in a state as culturally and geographically diverse as New York State, it's really the only way to achieve success. We're not going to have models that work well in one community always work well in another. We need the community-based organizations to kind of steer the ship, if you will. And I looked at the initial opening session chart, which kind of had a line, I guess it's like a growth line or curve. And I thought that was significant, somewhat symbolic, because it reminds me that, we're launching this rocket ship and we're building it as it's being launched. So, the success is going to be mixed. It's going to be a lot of work, but we're going to really rely on one another to share information, and that's really what part of the session is here today. So we hope that you'll all get involved. We hope that you'll help us play a vital role in advancing health equity, improving health outcomes, and achieving the overall objectives of reduction in readmission rates. But we also hope that will help steer the ship a little bit in terms of the New York State's healthcare reform strategy. The value-based roadmap is an important one, but it's very new. It's in the infancy stages. Value-based payment in general, even amongst healthcare providers, it's taken millions of dollars to set up IT systems, payment systems, to really look at the outcome measures involved and put that in play. And it's really at the beginning stages. A very small percentage of providers nationally are really involved in value-based payment. So we're learning as we go. Hopefully, and I'm very hopeful, it's going to really change the way we do business. But it's only going to happen that way if we step up at the table and we talk about successes and share them. We ask questions when they need to be asked, and we kick the policymakers in the shins a little bit to bring their attention to the needs that are in front of us as community-based organizations. And that's really why I'm thrilled to be here today. For those of you that aren't familiar with New York Statewide Senior Action Council, I just want to point out I did put some material up on the table along with a pen with our Patients' Rights Helpline. We do run a Patients' Rights Helpline. It's a statewide program. We have chapters here in Saratoga and Albany, but we also run CMS's Medicaid and Medicare fraud prevention program known as Senior Medicare Patrol. If anybody wants to talk about any of those things or about DSRIP, I'll be around afterwards. I'd love to talk to you. So I'm going to turn it over now to our next speaker. And Emily Rogan and I have been chatting, and I really, everything she says, my remarks to her were right on, because I think that she has the right spirit and the right knowledge and the right experience. And we're just so glad she's here to share that with you today.
So I'm gonna, can you hear me? I'm gonna take it from behind, get out from behind here, and then I'm gonna try to manage my paper, the clicker, and the mic. So this should be interesting, and I'm left-handed, so. No, I think I'm okay. I'm okay. I'm just going to have to go back to my notes a little bit. Maybe I will. So first of all, I just wanted to thank our hosts for inviting me to be one of the presenters today, and thank Anne for reaching out to me also. I'm really excited to be here and to share the work that we've been doing on Long Island for just a little over a year with the CBO planning grant from the New York State Department of Health. Before I get started and talk about, where is mine? Oh, there we are. But tell you a little bit about Long Island. I like to ask this question when I leave my little nook of the world. How many of you have been to Long Island? Okay, that's good. That's good. I know this isn't going to get recorded, but I'm just curious. I just would love some thoughts. When you think of Long Island, what do most of you think of when you hear? If I say, "What do you think of?" Just throw the ocean. Yeah, everybody says the ocean. What else? Traffic. Okay, that's true. Yeah, we have traffic. What else? Anything else? Jones Beach. Okay, so our experience is that often when people hear about Long Island, they think of wealth. They think of the Gold Coast. They think of the Hamptons. They think of Montauk. They think of the vineyards. And all those things are true about Long Island. That is, we have all those wonderful things that makes us all tolerate the traffic, because I will tell you, it can be horrible. Getting off the island's awful. But there's a lot of other things happening on Long Island that I think people just don't understand and don't know about. And I'm hoping that I can shed a little light on it for you today so that you can understand the need and why the work that we're doing under the umbrella of the CBO planning grant is so critical to communities in our region. And hopefully we're going to bridge some gaps between upstate and downstate. Just as an aside, I served for 12 years as a school board member. I was board president for 4 years, and whenever budget time came around and we had to all start, advocating for money, there's always this upstate, downstate kind of back and forth. And I think what I'm learning, and by working with the folks that I've been working with, is that there's a lot more we share in terms of successes and challenges. So hopefully my presentation will shed a little bit of light. So I work for the Health and Welfare Council of Long Island. It's I think the largest umbrella nonprofit agency on Long Island. We've been around for over 70 years, and we serve communities from Montauk to Elmont, so it's from tip to border. If I had to just describe what our agency does and why I think we became the lead for this grant, is that we sort of have, if you think of a three-legged stool, we do policy advocacy work, we do direct service work, and we do convening as inherently part of our work. So we were sort of a natural pick to lead because we were already plugged into other nonprofits on Long Island. So here's an interesting statistic that we talk about a lot, that when I talk about need on Long Island, so percentage-wise, if you look at our two counties, Suffolk and Nassau County, they don't have a high percentage of poverty. But when you look at the actual numbers of people, it's the equivalent of Buffalo, Rochester, and Syracuse combined. And that's something folks don't really know about Long Island, right? So what I will tell you, and if you drive around our region and you come out and visit, you can find tremendous pockets of wealth like you've never seen, and then less than a mile away, pockets of the most profound poverty and need. My classic example that I tell people all the time is Garden City versus Hempstead, and it's less than a mile drive between the two communities. Wonderful people in both communities, but the amount of access and resources, the distinctions are profound, and they're next door neighbors. So another piece that's really important to understand about why this grant is so important to us is our friends in New York City have some pretty strong infrastructure for health and human services to plug into with their government agencies. But on Long Island, it's a little different. We have two counties, we have 13 towns, we have 2 cities, 96 incorporated villages, and 124 school districts, all governed by different boards of education and administration. So when you talk about silos, when you go into each town and the levels of distinction in terms of how governance happens and the absence of infrastructure to support nonprofit agencies across our region, there's really never been a regional approach to really looking at how people's needs are met across the whole region. So this grant has really helped us take a good look at that. I happen to love this quote, and I'm not going to read slides to you, but I am going to read this one because I think it's so important. So why is this work so critical? Fully addressing social determinants of health requires a shift in power that enables marginalized communities to co-design their own healthcare solutions. Unfortunately, health insurers, while willing to alter payment models and entertain some changes in what they will pay for, have yet to grasp the more fundamental nature of the need for system change and community empowerment inherent in the idea that health ultimately is about much, much more than healthcare. And that was from the American Journal of Managed Care. Okay, so I think we all know that statistic now, right? What is it, 10 to 20% of a person's health outcomes has to do with their clinical care, and all the rest has to do with the social determinants. And what we like to say in our agency when people talk about social determinants is there's people's basic needs. There's nothing new. There's something new about that term, social determinants of health, but in terms of what they actually are, meeting people's basic needs where they live, work, eat, play, pray, that's always been something that we've been talking about, those of us that work in health and human service agencies, right? Okay. Okay, so why a health equity focus? So one of the things that we decided very early on, or that we recognize, is that while the idea of moving to a value-based payment arrangement is a good one, and we support the integration of services and everything, at the end of the day, that's about the flow of money, right? From a managed care organization throughout those kind of concentric circles, through the health systems and primary care providers and behavioral health providers, and then to the social determinant providers or the health and human service agencies and nonprofits. But what we are always thinking about in terms of nonprofit agencies and the people we serve at the grassroots level is always the persons in the middle, right? And so how do we meet their needs? And so what we have is, it's not that they're in conflict with each other, but we have to find a way to not forget about that piece while that piece is happening. And we see it happening. I'm not saying it's not happening, but it's a little bit more slow to develop. Does anybody have any questions so far? I talk fast. Everybody with me? I know this. How many of you even heard the term DSRIP, VBP, or PPS, or CBO up until a few months ago? Like, is this new? Because this was relatively new to me not so long ago. Everybody's with me on that? We're good? Okay, I know it's the post-lunch presentation. Everyone's got the yawns. Okay, so why a Health Equity Alliance? So when we kicked off our grant work last year, it was, I'll tell you a little bit more about all the alliances, but or the consortia, but we had our big kickoff, our Health Equity Summit, back in March of last year, and we really decided that all the work we would do with the CBO grant had to have a health equity lens. It had to really look at how are we reaching the people that need to be served the most. And so we really decided that it's a two-prong approach. It's a systems change, but it had to have that equity lens on it. Otherwise, we couldn't do that work. So that was kind of the driving force behind it. Okay, so the CBO planning grant, I think most of you probably know that it was a $2.5 million grant awarded by the New York State Department of Health that empowers CBOs to. So these are some of the goals, or the big reaching plans of the grant, at least from our perspective. There were, I think it's important to point out, there were 3 different grants awarded. So New York City was the first one to start the work. They're done. Their consortia was called the CTHE, which was Communities Together for Health Equity, I believe. I think they wrapped up their work last fall, if I'm not mistaken. And then our grant that I'm the manager for is for the Hudson Valley and for Long Island. And what we decided very early on is, if you know anything about the Hudson Valley and Long Island, we're pretty distinct regions, is that we're working together but separately. So they kind of formed their own governance structure, their own consortia, and the state gave us their blessing on that. It just didn't make sense. There was no way we could have done it together. And so I report to the state for both areas, but I manage pretty much all the work just strictly for Long Island. But these were some of our big picture goals, if I could sort of encompass it. And so the next consortia, which you're going to hear about and hear from, which relates to all of you, is the rest of state. And you got your award when? Just started December 1st. So ours also, we found out in December of 17. We started the work shortly thereafter, and we're in the middle of our no-cost extension right now. So we've been in communication. Ann and I got on the phone pretty early on, right? So it's been great. Oops. So just really quickly, I'm not going to spend a lot of time. This is our steering committee members. We have 5 agencies on our steering committee. We made sure that they represented sort of a broad picture of agencies and services on Long Island. So we have the Health and Welfare Council, Harazin, which serves the immigrant community on Long Island, Child Care Council of Nassau, that's obviously do child care. And there's 2 major child care councils, one of Nassau and one in Suffolk in the region. Choice for All is a real grassroots community-based organization doing a lot of work in an area of of Long Island called Roosevelt, which has really been a largely neglected community for a very, very long time, and they're doing some great work. Long Island Against Domestic Violence and the Long Island Coalition for the Homeless. And we are very fortunate. We have a very engaged, robust steering committee that's very much supportive of the work that we're doing throughout the region and really gives us some great ideas, and it's been a pleasure working with them. And these are the members of Healy's qualifications according to the state grant. So we have 50 Tier 1 CBOs, and actually the Tier 1s are the ones that are written into the grant. So that means that they're 501c3, non-Medicaid billing, annual operating budgets less than $5 million, experience providing community-based services that address social determinants of health for, I think it's 2 years or 3 years, but all of ours have been doing it for forever. So we've got 50 right now in our consortia, and then we also really thought that to be comprehensive in the work, if we're really gonna do systems change on Long Island and really look at it, we had to invite our friends who are Tier 1 agencies. So we've got about 33 Tier 3s as well. And they've really helped to inform the work and give us context. And so they don't qualify for the honoraria for the grant, but they're very much engaged in the work, and they see their role as well. So this is the geographic diversity of, in case you didn't know what a map of Long Island looks like, now you do. But that's kind of where all our agencies are. And these are the different types of services that our agencies provide. And you're going to hear me say this more than once. We will stand by the argument that you cannot meet people's needs by serving one social determinant of health. We really believe that anything that happens, whether it's a value-based payment arrangement or any other kind of investment in community, it has to be holistic, because it doesn't make sense that if I just go to you and say, here, I'm going to feed you because you're hungry, that therefore your needs are going to be met. That often, more often than not, there's multiple services, and that's why we want to have such a diverse group of folks sitting around the table having this conversation, because investment in community and preventative care is ultimately what we believe is going to not only improve outcomes, but also reduce costs and avoidable hospitalizations. When people's basic needs are being met, when they can live healthy, productive lives, when they have opportunity for economic stability and growth, the chances are they're not going to end up in the ER so much. And that's what that's like sort of the driving message that we come from all the time, is that we have to invest in people where they are and help raise them up. And these are the populations that we serve. And there's probably more that isn't up there. So we didn't want to get too bogged down in governance structure. I think sometimes with a grant, you could spend all your time, worrying about how it's going to get done, and then you never actually do the work. So we were pretty quick with our whole group to come up with some brainstorming, and this mission was a collaboration from everybody and with input from the whole alliance. Again, I'm not going to read it to you because I think everybody can read, but basically, our goal, I'll move on to our goal. So our vision, I think, is really important. We are looking at building and providing an integrated, holistic, culturally and linguistically responsive health and human service delivery system that results in equitable health and life outcomes for all Long Islanders. We don't want Long Island to be a place where your zip code determines your health. We want everybody to have a fair shot at having a quality, healthy life. And so that's what we're all working towards. And these are the goals that we came up with. If I could sort of drill down on the 2 big picture things that I think the grant is helping us do, is we are really looking at service delivery. So we see that and again, we're not talking about from the top down, from the hospitals or from the government. We're talking about at the grassroots level, at community level. We did a brainstorming session and we sort of said, what are we really, really good at and what are we not so good at? And what, if we could wave our magic wand, what would that look like, right? And these were some of the goals that we came up with, because what we recognize is most of us are really, really good at what we do in our communities, but we tend to get siloed just like everything else. And we believe that there's two pieces that have to fall into place. One is some kind of an intersector care coordination model where when agencies make referrals to each other, there's follow through, you can track it, you can see what happens, you can get back to each other, because a lot of us work with what? Notebooks and phones and sometimes technological referrals, but not often, right? And then on the other piece, a technological IT platform that we can not only communicate with each other, but also ultimately communicate with our PPS partners, with our government partners, with our funders, right? So, but the difference is that we're looking at it from a Health and Human Service Agency grassroots level moving up as opposed to top down. Does that make sense? Okay. So then we did a quick survey. I didn't want to bog you down with the survey. It was short. It was 6 or 7 questions. And from that survey, we basically came up with the need for 3 work groups. So we have 3 work groups. We have a data technology work group, a community engagement work group, and a policy and advocacy work group. And each work group came up with its own set of goals that they were going to focus on. And I will tell you that right now, well, actually, I'll show you later on. So this is our data technology work group, community engagement. And we're being very, very careful not to go into our communities, to our consumers and to our clients yet, because we don't know yet what we're going to be presenting them with. And I will tell you, if I've learned anything in the year and almost half of this work, is that people are suffering from fatigue. They're survey fatigued, they're program fatigued, they're tired of folks coming in and saying, we're going to help you, and then they say, oh, it didn't really work out, and they leave. And we don't want to ever do that. So we want to really make sure that we don't abuse the trust of our communities and of our member agencies. So we're really being very careful. So we're coming up with ways of how we can best reach community, but until we have something to really deliver on, we're not digging in deep that way yet. And then our policy advocacy committee, they have come up with different ways that we can, as Marcus was talking about, inform the state. Look, we think this is all great, great work, and we're very grateful for the funding and the support to be able to do this work, but it's not perfect, right? And there's definitely places along the way where we think that if there's DSRIP 2.2 or 2.0 or whatever happens next, that things could be a little bit different. So our policy and advocacy work group has done a really nice job. We sent a letter to the state back in, I think, September from our CEO on behalf of Healy regarding the roadmap and some things we thought could be changed or different. I spoke at the Medicaid redesign team's public comment forum back in New York City in November, and also gave some input on what we think could be improved upon. So these folks have been working really hard, which has been great. And I think one of the things that we really need to do is do a better job of telling the story of suburban poverty and health disparities. So here's some highlights of our work groups. The data technology work group, right now it's really exciting. We ended up hiring an organization, a company called Intrepid Ascent, to really do a deep dive into our data and to find out what do we everybody knows there's this sort of misconception that small nonprofits don't have data. Well, of course we do. All of us get grants. You have to be able to report on what you're doing in order to get more grants, right? So we have the data. It's just a question of how we can bring that data together, right? And we believe it has to be collective, not kind of one-off agency by agency. So we're right now in the process. They just did a data assessment survey and got great response, and now we're sort of stepping into the next piece, which will be in-person interviews with all of our, with not all of, but multiple people from our membership. And I talked about the other 2 things already a little bit. So these are some of the folks that we've had come speak. We've invited folks who have already started to implement new coalitions and new models or new ideas. And I would tell you, if you don't know a lot about the work about Families USA, it's a national organization. I strongly suggest that you get on their website. They're doing they have a whole new initiative all around health equity in the healthcare transformation process. And they're doing great work. I went to their conference back in January, and it was very, very inspiring. These are the folks that we've had come to speak about whether it's systems change or service delivery models that we could sort of consider as Long Island moves ahead. And this is the data deep dive that I was talking about before. So we're really going to look at everything. So one of the things we want to do is identify and ultimately at the end of the grant have a business plan and then also an RFP ready to go for some kind of integrated data platform. But in order to be able to recognize, what we need to know what we didn't know, and we need to know what we needed. So that's what we're in the middle of doing right now. And I, by the way, am not a data wonk. I'm a communications person. That's what I do. And I'm learning a lot. So it's been really, really exciting, and it's exciting to see how engaged our folks are about this. So this is something I pulled from my statement back in November. I think one of the things that we're going to continue to advocate for is upfront investment in community-based organizations. So the state took a nice step with this grant, and we're thrilled about that. But we know that ROI on health and human services doesn't happen quickly, right? When you invest in communities, it's not an overnight change, but a lot of communities, especially I'm gonna say on Long Island, they're divided by race and by socioeconomics by design. And it's been institutionalized, and it's been like that for a really long time. So one small program to address asthma or to address obesity isn't going to change people's lives. And so we are gonna continue to advocate for the fact that we think it needs to be a holistic upfront investment. And it is happening. It is happening. There are places, the one in Toledo, they figured out that if we invest in employment, and we help give people a way to support themselves and to have jobs where jobs didn't exist, we're taking a calculated leap of faith that it's going to improve health outcomes, but it's not going to happen tomorrow. And so I think that that's really, really important to keep in mind when you're looking at this from a health and human services perspective, not from, just how are we going to save money and keep people out of the hospital, but how are we going to invest in communities and really raise everybody up so, hospitals don't have to be inundated with people that don't belong there. And this is something I've talked about a little bit. We are seeing some disturbing things with services getting pulled out of community, getting more institutionalized. That's concerning to us. We think that, you've heard this said more than once, that there were some input, but not to the depth that I think community-based organizations really needed to have input on the work. But we're doing it now, so that's really good, and that's exciting, and we've been working closely with our partners in the PPS, and not so much, we're not having a lot of conversations with our MCOs yet on Long Island. That's not happening yet, but I hope that it will. As soon as we have our product that we are going to be sort of marketing. When we talk about what we'd like to see on Long Island, we really believe, so I'm just gonna, and I'm almost done, but this will really illustrate something for all of you in the room, regardless of where you work. So we went to a conference a few months ago, a local conference, and they had a person it was a healthcare provider, there was a managed care organization, and there was a fairly large CBO sitting on the panel. And they were all talking about this great work that they're doing. And they are all doing really great work to try to help people, right? And to improve outcomes and serve communities and serve clients. And then at the end of the panel, when it was time for questions, my COO that was there, she raised her hand and she said, well, you've all talked about what you do. How do you integrate care and care continuum between the three of you? And they all kind of shrugged and they said, we don't. And so there's a gap there that we believe at Healy that health and human service agencies, that nonprofit agencies can fill that gap. That we are uniquely positioned to coordinate care for people both within the health and human service sector, with with healthcare providers and with managed care organizations, because we're the ones that we've been in communities for years and years. It's not a fly-by-night thing. We're there working sometimes with no funding to help people. So imagine what we could do if we were sufficiently funded to do that work, right? So we really believe that that's the best investment anybody could make. And we also believe that it's sort of that's one-stop shopping of all social determinants of health is in this consortia of all these different agencies working together. And I love this slide. I mean, there's all those equity, equality slides, right? But this one, I think, tells the story the most. So that's it. I'm done. Should I not take questions, or should I? Do you guys want to wait to the end for any questions or comments or anything? No?
Thank you, Emily. Let's go. Whoops. Uh-oh. That is... sorry about that. Get you dizzy. So you can see why I keep Emily on speed dial. Her inspiration is contagious, and the work that they've been doing in Long Island is fantastic. I'm Ann Battaglia. I'm the CEO of Healthy Community Alliance, and again, thank you for inviting us here today to talk about the work of the CBO Consortium in the Rest of State grant. So just quickly about Healthy Community Alliance, we are a rural health network, so that we're one of the 32 rural health networks that are funded by the Office of Rural Health. We are in a small community in Western New York, south of Buffalo, and serving rural residents in that, you wouldn't know it, but it's called the Route 39 corridor, and we have a lot of rural communities in that corridor, but we're also providing a lot of services throughout the Western region. We've been funded since 1996 under the Office of Rural Health and continue to grow from there. And our mission is to improve the quality of life in rural communities and do that through broad-based community partnerships, supporting wellness and prevention. And we are an organization, we are a CBO. We provide social determinants of health for our communities. We provide access to care. We provide navigation in the health insurance marketplace. We have a food pantry, we have affordable housing, so we are doing the work in our rural communities that is focusing on meeting those non-traditional, non-medical needs for our population. In addition, we work hard to be a leader and an expert in our community and forge partnerships and leverage more funding for our area. So again, we are the lead agency for the Rest of State CBO Planning Grant, and as you heard from Marcus and Emily, there are 3 funded organizations. The Rest of State got a little bit of a late start. New York City's grant is concluded, Emily's in her no-cost extension, and the Rest of State CBO Consortium started its work December of 2018. For those of you that were involved earlier, you might know that there was another grant award that was issued to another rural health network. There was kind of a false start there, so a couple of years later, we're trying to catch up. But we're super excited to be able to have picked up that ball, carried it over the finish line, at least from the contracting stage, but again, right at the beginning now, to your football reference, I had to throw that in there. But at the beginning stage now of the work that's happening. We do have a consultant, Coordinated Care Services. They are involved with us. They're going to be leading the technical assistance portion and helping us with the strategic planning portion of the grant. And certainly the grant requires an evaluator, so Common Ground Health out of Rochester will be working with us to evaluate the outcomes of our grant. So you can see the Rest of State is all those colors other than the gray. We have 48 counties in our regions. We have broken those out into 5 regions. But again, it's a heavy lift for the Rest of State. And a lot of the work that we've been doing in the first 3.5 months has been really just convening, really just trying to introduce ourselves, reintroduce the work, re-energize the CBOs because of as Emily mentioned, the fatigue that's been happening around potentially disrupt some of the CBOs that were engaged initially in the early stages of the consortium efforts. So our planning grant has 3 aims, and these are really our charges in the grant, and it's to identify and engage community-based organizations in the consortium, and these are community-based organizations that may have already been involved with their performing provider system, maybe have attended or know a little bit about value-based payment and DSRIP through conferences, but it's also identifying those community-based organizations that have really not been engaged at all up to this point, but are doing very, very important work in their communities. Our second aim is to improve those community-based organizations' ability to analyze their business requirements, to build their business acumen, to better identify how to measure the work that they're doing, to measure the outcomes, develop their value proposition, and hopefully be effective in helping meet the district's goals of reducing those avoidable hospitalizations and admissions. And lastly, really to position the consortium and its members for longer-term engagement, identify sustainable funding opportunities that we might be able to continue the work of the consortium and the community-based organizations in full system transformation. So our consortium structure is that we do have a steering committee, we have a project management committee, we have our 5 upstate regional leads, because there's no way we're going to be able to do it from Western New York, so it's really important that we have active regional leads in each of our 5 regions. And then we have county co-leads that are working in individual counties to make sure that we're recruiting, we're reaching out to those community-based organizations that have not been engaged, and also making sure that we have a good cross-section of community-based organizations that are addressing a multitude of needs of the social determinants of health. We're also, as Emily had indicated, they have Tier 1 CBOs as members, but we're also seeking out and inviting Tier 2 and Tier 3 CBOs into the consortium as affiliate members. So our regional leads, we do have Population Health Collaborative in the Western region. They're very active in the 8 counties of Western New York. They're our Population Health Improvement Program, and they also address chronic disease self-management and diabetes self-management activities. In the Finger Lakes, we have Catholic Charities of the Finger Lakes. South Central, our Rural Health Network of South Central is our regional lead. And then our Capital District and North Country are represented here. So Marcus with Statewide and his team is our regional lead for the Capital District. And Anne Marie from St. Lawrence County Health Initiative is the regional lead for the North Country. And they've been working hard. And we thank them. So this is just a quick graphic of the structure of the consortium with our steering committee in the middle, our regional leads, our county co-leads, and then the general consortium. So again, our first aim is to identify and engage those community-based organizations that may not have been already engaged in district activities or maybe have and are ready to potentially move on to some more advanced technical assistance. And as you'd heard from Emily, the criteria for the grant for participation, full participation as a member, is that that community-based organization has to be a 501c3, nonprofit, has to have a budget of under $5 million, address social determinants of health for 2 or more years, and currently not bill Medicaid. Our goal for the rest of state would be we'd love to have 500 CBOs in our goal. In our consortium, it's lofty. It is. The first grant that came out was 1,000, so we did back down from that. We have 140 right now, and continues to grow. We have additional affiliate members in the consortium as well. So that's our heat map of our CBOs and where in the state they are doing their good work. And similar to Emily's graph, these are you can't see it too well, but these are the social determinants of health that the community-based organizations are currently addressing. Most organizations are addressing many social determinants of health. So it's not just, a food pantry, but when somebody comes into the food pantry, they're also getting SNAP applications or other referrals. And we're really trying to get a good sense of where our community-based organizations are working, and again, if there's community-based organizations that we want to continue to invite into the consortium, what social determinants of health are underrepresented. Our second aim for the grant is, again, to improve those engaged community-based organizations so they can better position themselves to participate in district activities. So right now we're collecting feedback from our community-based organizations on what their needs are. We're also speaking with our performing provider systems, really to get an idea of what activities are already happening, what strategies the performing provider systems are working on to engage and build acumen for our community-based organizations, such as this event. We're doing thought leader forums, so I was happy to see that a couple of you had attended the thought leader forum in Plattsburgh and in Albany. We held one in Rochester this week. We've been in the South Central region, and we've been in the Western region. And at those thought leader forums, we're really doing a SWOT analysis, if you will. What are the strengths of the region? What are the strengths of the community-based organizations? What technical assistance would be helpful so they could continue to grow and be a stronger and thriving community-based organization? And then what opportunities are available in the region, whether it's locally, regionally, or statewide? And then certainly, what are some other things that we need to be thinking about from a partnership perspective, ways that we can align our community-based organizations or our consortium to better move this work forward. And continuing on, once our survey is out right now, so if you are an engaged community-based organization and you haven't filled out our survey, please do so. That's really what's going to inform our technical assistance programming. We're developing a curriculum based on those needs. We have some assumptions of what community-based organizations may already need, but the feedback from the thought leader forums and the surveys are what's going to give us a really good sense of where folks are and help us even stratify organizations based on information that they've already received, technical assistance that they already have, or where they are in this process. We're building an infrastructure to be able to share that learning. We're working on a learning management system that will be available to our members that they can share with their staff to be able to take advantage of those trainings and technical assistance in a virtual way. And then certainly looking at plans for evaluating the work. So our preliminary feedback, none of this is going to be a surprise. I'm sure it wasn't a surprise to us, but there are community-based organizations that still are trying to understand what that alphabet soup is, right? The DISRIP, the PPS, now the BHCCs, VBP, social determinants of health, the RIO, all of those. So, we expect that there will be some CBOs that don't need that and others that will find that information very helpful. Certainly, CBOs are interested in information on how they could work on developing their value proposition, how they can better measure the work that they're doing and communicate that. Certainly legal, contracting, and negotiating, how do we make that ask? How do we go into those conversations with potential payers? IT, data collection and reporting, we hear that over and over and over again, and it's exciting to hear that your work group is kind of leaning into that, and that's going to be one of the areas of focus of the Long Island Consortium. And then strategic partnering and alignment. We know that one CBO can't do it all. We know that managed care organizations are not going to have contracts with a multitude of CBOs. So how can, as an organization or a consortium, we align, with other partners and really have strength in numbers to be able to take our outcomes and our stories and move forward into a potential new opportunity for value-based payment. And then certainly, how can we as a collective identify ways that we can mine data, obtain data that will help inform our work and help us move into those payment arrangements and better understand where the community needs are and where those hot spots are. This is just a quick infographic about how we plan to deliver the technical assistance. So our lead consulting agency, Coordinated Care Services, is going to be working with other technical assistance providers and consultants. We haven't identified all of those because we're really waiting for feedback from our community-based organizations before we build the curriculum and identify the best consultants that can help deliver that material. Whoop, boy, got a little thumb happy there. Okay, thank you. So as you'd heard earlier, there is funds that are being paid out to community-based organizations for their participation in the program. That honorarium is available to our Tier 1 community-based organizations. We are able to provide payment for their participation in leadership activities. So our regional leads, our county co-leads, for their participation and their leadership in their communities and in their counties, will be receiving payment. Plus we have payments that will be available for CBOs that participate in the technical assistance webinars, trainings, learning collaboratives. So, as you heard from Marcus, that this is really exciting that we're able to be able to flow those funds out to the community-based organizations and offset some of their costs for the time that it takes to attend and participate in this work. And in our 48 county region, we have 10 performing provider systems. And again, we know that those performing provider systems are doing great work in their transformative efforts. Many have a robust community-based organization strategy and engagement strategy that they're working on. We're doing what we can, just like we are today, being able to have conversations with those performing provider systems, find out what our synergies can be, where we can complement each other. Right now, we're able to cross-refer community-based organizations. If we're not ready to deliver that training yet, but we know a performing provider system is doing it, we've been able to navigate our community-based organizations over to that activity, and we're seeing the same from our performing provider systems in referring organizations to the consortium for potential membership. And our third aim is to explore ways that we can sustain this work so that we can have a longer term impact in system transformation. And you can hear where Long Island is. They're at that point where they have been working on their strategic plan. They've identified some areas where they really think their consortium can be effective for their populations. And we hope to do the same thing with the rest of state grant. We do know that 48 counties, there's not going to be one strategic plan that's going to work for all 48 counties, but we're expecting that these strategic plans will grow organically in those regions, and maybe within those regions that there will be opportunities that the consortium in each region can find ways that could potentially sustain the work that they're doing as a collective. We're hoping that, the consortium can identify workable models that for CBOs that can align with one another, can align with other opportunities for, payment, data collection, and reporting mechanisms and structures. We're hoping that the CBOs can be a collective, and as you heard from Emily, to really be a voice at our local level, our regional level, and at the state level, because we know that true system transformation can only happen when the community-based organizations are at the table designing the next step of this work. I think that's pretty much all of it. And I would like to turn it over to Anne Marie now, again, our regional lead for North Country, and she'll tell you a little bit more about what our next steps are and take any questions and let you know if you're a CBO how you might be able to engage.
Thank you, Anne. Excuse me. Thank you to Marcus and Emily as well, and to our hosts. We're very excited to be here. As Ann mentioned, I work with the St. Lawrence County Health Initiative. I'm the executive director at that rural health network. Our mission is to measurably improve the health of our community residents through a collaborative community effort. And that last portion of our mission is my favorite portion. A collaborative community effort is exactly the reason why I got involved in this CBO grant several years ago, and again signed on when Ann said she was going to tackle this beast. I jumped on board because I recognize the need for us as community-based organizations in healthcare systems and PPSs and FIPS and everyone else to work together to achieve our individual missions. And this is an opportunity for us to work together across all of these and meet those goals. So while it's not very funny, it did make me laugh when Emily remarked about walking within walking distance in her service area, the disparities between one area and another. And the HCA took on the CBO Rest of State grant, which is 48 counties. It's a beast. We are all so very different. Just in our region at the Health Initiative, we work with our partners differently in one county than we do in another. We serve our clients within one program differently in one county or community than we do in another. And we're talking about 48 counties across the state with all of us having different missions. Yes, we are working to achieve the health of community residents, but we're very different. It's a beast. And I think that you could hear when Ann was talking about this work that she is recognizing how it's not set in stone. We need community-based organizations to hop on board and say what they need in order to make this work. So that's really where we're going with it. It's not going to necessarily look exactly what Long Island is doing and what Emily mentioned, which is absolutely fabulous. But we're very different as the rest of state, both across the 48 counties and compared to Long Island. Am I right?
You're right, and I would just add to that, sorry, but I mean, I think that that's such an important point, and I wish I had made it, because that's true with each of the consortia, and then within each of those networks too. So there is no one size fits all, and I think that how people interpret the work of the grant has to be directly related to their specific needs and regions. So I give you guys a lot of credit for that because it's a big, big area. But yeah, that's true.
Thank you. So Ann did a great job outlining some of the moving forward, but I want you to remember a little bit about what I said, that it's up to you as community-based organizations and affiliate partners to really say what this is going to look like, both in your county, in your region, and across the state. So Ann has provided here lots of opportunity to get involved. There is not only an actual CBO sign-up form, and that has the contact information form as well, so you can take that with you and review it or fill it out right here. But we also have the affiliate agreement form on site, so we encourage you to sign up today. If you really just want to learn more information on a one-on-one basis, both Marcus and I are really open to chatting with you about what it looks like, what's going on right now, what stage we're in, but also at Healthy Community Alliance, they've been absolutely fabulous, both Ann and Tony, in talking to consortium members or potential consortium members. So I encourage you to pick up the phone, send an email, get in touch with us.